Good morning, everyone. This is Shannon Spitkowski. I'm the clinic coordinator for Cardi-OH, and we're going to begin our fifth in the series of our echo clinics on hypertension. I don't see anyone who's joined on the phone, but if you'll please enter your name and your role into the chat function, we can record your attendance. We'll go around the room here and introduce ourselves. Dr. Rao.
Good morning, everyone. Hope you can hear me reasonably well. I'm Gautam Rao. I'm the director of the ECHO program for cardio.
Hi, I'm Jackson. I'm emeritus professor of medicine here at Case Western Reserve University, University Hospitals, Cleveland Medical Center.
Hi there, Jessie Lewis, project manager here at Case. I'm Ann Nevar. I'm the program director for cardio.
Hi, and I'm Rick Carnacci. I'm the web content producer for cardio.
Excellent.
Okay, thanks everyone. So I just want to give you a brief overview of the hour. We're going to start with a presentation by Dr. Holliday on advances in pharmacotherapy. And this isn't just from sort of the pharmacological or developmental standpoint, because there were certainly advances there, but I think it's more also in terms of, just looking through his slides, in terms of compliance and adherence. I was in a meeting a couple of days ago about diabetes treatment, and a lot of criticism from diabetologists about how simplified our diabetes treatment is. It's just basically metformin, a long-acting insulin, and we kind of stop there. And I just pointed out that the best regimen is the one the patient is actually willing to take. So even though you might have some new and fancy things, it really doesn't help if nobody actually uses them. So Dr. Holliday is going to do that. And then we have a couple of case studies by Ann Fesco and Candy Reinhardt, which I think will highlight some of the challenges that we all face in terms of treatment. And of course, we'll have our discussion after each of those cases at that point. So I'm going to turn things over now to Michael to get us started with his presentation.
Okay, can everyone hear me okay?
Yes, we can.
Okay, great. So I just wanted to start off with sharing an experience that I've had many times. That's when I'm measuring the blood pressure for the second time, because the first one was high. And I'm just kind of rooting along for that blood pressure to be lower, because I'm not sure what I'm going to do. I'm going to have this conversation with the patient, perhaps see if they're even taking their medicine. So hopefully some of the slides today and some of the discussion will help us face that situation a little bit more confidently. Next slide. Here's the disclosure statements. I'm not going to read through these, just want to take a look at these quickly. And next slide. Okay, so I've got a couple objectives to discuss today. One objective is just that hopefully we will be able to identify blood pressure targets for hypertension pharmacological treatment for our patients. We want to learn how to use a patient-centered approach to arrive at more effective antihypertensive regimens. And then finally, we want to learn how to use underutilized medications to achieve more intensive blood pressure target. Determinants of patient-centered pharmacotherapy. This is a spoiler alert. There are more than 3, but we're going to discuss these 3 primarily today. We want to learn how to diagnose the blood pressure or hypertension by assigning specific thresholds for diagnosis and also treatment targets for our patients. We want to utilize effective drug combinations, ones that will lower blood pressure and be more likely to be taken by patients. And then also we want to consider interventions that can increase adherence to therapy. Next slide. When we talk about the accurate diagnosis of hypertension, this slide just brings up the idea that we really need to utilize more than clinic readings. We need to have some type of mechanism to get out of office readings, whether that's home blood pressure monitoring or ambulatory blood pressure monitoring. Next slide. Some of the advantages of using out of office data include the reality that many of our patients have higher blood pressures in the office than outside of the office, and out of office readings are more likely to correlate with cardiovascular outcomes. So we don't want to treat patients with antihypertensive medications when they're not warranted and may cause harm. So this would be so-called white coat hypertension. And then also there's masked hypertension, in which readings are more elevated outside of the office, and we need to adjust our therapies to meet that reality. The other benefits, we know that this is going to improve patient adherence, and we'll get into that in a little bit. And the typical protocol for measuring at home is 2 readings separated a minute or so apart in the morning, and then repeating this in the evening, typically not very late, but more like before dinner or so. And then doing this for a total of a week, but throwing out the first day's reading. So you end up with 24 values over the week. And this can be used to confirm a diagnosis of hypertension. It can also be used for blood pressure monitoring between visits in the office. And once we do collect the data that's required via the latest guidelines, we could categorize that patient into either a normal blood pressure of less than 120/80, elevated blood pressure of 120 to 129 over less than 80, stage 1 hypertension, which is 130 to 139 over 80 to 89, and finally stage 2 hypertension, which is greater than or equal to 140 over 90. Next slide. And before we decide how to treat these patients, whether it's with lifestyle therapy or lifestyle and pharmacotherapy, we need to calculate the patient's cardiovascular risk. This is typically done using a calculator from the ACC-AHA. This is a atherosclerotic cardiovascular disease risk over 10 years. And what I want you to see on the slide is that when we're choosing a threshold for treatment with medications, there's really only 2 patient types that do not have a threshold of treatment of 130/80. And that would be patients with no prior clinical cardiovascular disease, and also a 10-year risk that's less than 10%. And also patients who are being treated for secondary stroke prevention. So these are people who did not have a history of hypertension prior to the stroke. They've had a stroke, they've recovered, but now we are trying to prevent another one. And this is also initiating blood pressure medications at 140/90. Interesting, if you look at the therapeutic goal, our goal for all patient types would be less than 130/80. So this is definitely a change when we are looking at the new guidelines compared to other guidelines such as JNC8. And next slide. Now this results in some challenges because we know that we're having adherence problems and blood pressure control problems with the old guidelines. And these are only going to be magnified as we strive for lower blood pressure targets. And the reason why I'm talking about adherence here as opposed to later in the talk is I firmly believe that adherence needs to be dealt with head on, because if we were relying on reacting to when it is expected, it's going to be difficult to be successful. Urine studies show that partial non-adherence is present in over 1/2 of our patients, and there's absolutely no drug, no antihypertensive drug in 1/3 of patients. And we also know that subjective efforts to detect adherence problems are not very good, whether these are direct, so we just ask patients if they're taking them, or even indirect when we normalize the reality that it is difficult to remember to take these medicines. But there are some promising interventions that are evidence-based, and these include regimen simplification. So if we can decrease the number of pills by using fixed dose combinations, also reducing out-of-pocket costs for our patients, and utilizing team-based collaborative care to support frequent follow-up of patients, both out of the office and in the office, and then also utilizing self-monitoring of blood pressure. This has been shown to improve adherence. Next slide. I'm guessing everyone was expecting an algorithm at some point in this talk, and rightly so. So we're going to discuss 2 different algorithms for blood pressure treatment. And this first one is the hypertension change package algorithm. And as you can see, once the diagnosis of hypertension has been made, we institute lifestyle modifications, and then we start a low-dose combination drug, namely an ACE inhibitor / diuretic or an ARB/diuretic combination. And this is in a low dose. And if blood pressure is not controlled with this, then we up the dose of this, we titrate it upward We're watching for side effects. We're watching for response to therapy. And if we're still not controlled with this, then we're going to add a third agent, which is going to be a dihydropyridine calcium channel blocker, such as amlodipine. And we're going to titrate this up as well. We're going to continue to encourage self-monitoring of blood pressure and also reinforce lifestyle changes. And then finally, if this 3-drug regimen has been optimized and we're still not under control, we're adding a fourth agent, which is typically spironolactone, as long as there's no contraindications. And at this point, when we're adding a fourth agent, we may want to consider changing the hydrochlorothiazide to chlorthalidone, which is a much more potent drug, and we will get into that a little bit more. Finally, if we're still struggling here, we can consider adding a beta blocker and perhaps guanfacine, so that's similar to clonidine. We wouldn't want to add a beta blocker and that drug at the same time because of the risk of bradycardia. And if we're adding these like a fifth agent, we might want to consider non-adherence issues, white coat effect, also secondary hypertension, and we may want to consider getting a hypertensivist involved. One of the advantages of this protocol is that it's relatively inexpensive combination therapies. It does seem to work for many patients, but one disadvantage is in practices that have a high number of African Americans, we may have some control difficulty because we're not optimizing thiazide diuretic use. Many of these patients will end up on a dose of hydrochlorothiazide that is 12.5 to 25 milligrams. And as we'll see in a little bit, that is often inadequate to lower blood pressure in many patients. If the patient's not well controlled with a thiazide, we are adding a complementary drug. If that complementary drug addition is not helping, we are adding amlodipine, and we're titrating that up to 10 milligrams a day. Alternatively, if we had started with amlodipine, we are making sure to get chlorthalidone on board. And finally, if we're at 3 drugs again, similar to the other protocol, we are utilizing spironolactone as a fourth agent. We're also considering using a beta blocker if the patient's heart rate is greater than 70. And we would want to use a long-acting beta blocker such as metoprolol succinate as opposed to tartrate. And finally, we're considering getting a hypertension specialist involved if we're still struggling at this point. This protocol may be better for practices who have a large number of African Americans because they would tend to respond better to an effective thiazide regimen such as chlorthalidone. And to make this point a little further about the diuretics, if we look at the outcomes data of different trials, the outcomes data is excellent for thiazides. We see one exception in which the thiazides were not superior to all other agents, and that was in the ACCOMPLISH trial. And not coincidentally, the regimen used was hydrochlorothiazide in a dose of 12.5 to 25 milligrams. And this is a similar practice pattern that we see in many of our practices because of the combination drugs that are available and just the convenience of using what we are used to. But this slide shows that we should probably consider getting off of the hydrochlorothiazide habit, as many people say. And the reason for the difference between chlorthalidone and hydrochlorothiazide has to do with the drug's pharmacokinetics. So because it is so long acting, this drug is less likely to cause troublesome side effects. So patients do not feel this quick onset of urinary urgency. It also tends to be more forgiving when it comes to missed doses because of its long half-life. We see a similar effect with calcium channel blockers as well, particularly amlodipine. Like chlorthalidone, it has a very long half-life. It makes an excellent addition to regimens regardless of age, race, or renal function. In patients who do have kidney dysfunction, we want to be mindful to add an ACE inhibitor, particularly if they have proteinuria. Then next slide. We also want to talk about using spironolactone because I think many patients are going to require this. This is a potassium-sparing mineralocorticoid receptor inhibitor. It is the preferred agent, obviously, for treating Conn's syndrome, primary aldosteronism. And it's also been shown to be effective in many other patients with resistant hypertension. This could be because Conn's syndrome is one of the most common secondary hypertension etiologies. And also many of our patients with resistant hypertension are in high aldosterone states, such as obesity and sleep apnea. And we know that treating sleep apnea with CPAP is not completely effective, and we often need to add spironolactone. It's a great complement to deal with the hypokalemia, which is found with chlorothalidone, which can be an issue. Many people are concerned about using spironolactone because of gynecomastia and impotence, but this usually does not happen at therapeutic doses of around 50 or less. Next slide. There's a trial called the Pathway 2 trial that looked at what was the best fourth agent if the patient is already on ACE inhibitor or ARB, a thiazide, diuretic, and calcium channel blocker. And this study showed that spironolactone, if it's not contraindicated, is the ideal choice. And this was compared to Bisoprolol and also Doxazosin. So kind of in summary here, I would just say we want to try from the outset to utilize regimens and also adherence strategies that are likely to give the patient success. And hopefully there's a little bit of time for any discussion and questions. And also I'd love to have Dr. Wright's input as well. Thank you.
Thank you, Michael. Great presentation. Thanks so much. So first, I think we'll start to open it up to any questions, either on the chat or if you'd like, you can unmute yourself individually, or Rick can unmute you and can ask a question over the audio as well. Give people about a minute or so.
Hello.
Yes, go ahead.
Hi, this is Christy at Crossroad.
Hi, Chris.
Thanks, Mike. That was great. Question about starting out ACE inhibitors after your diuretic. So it looked like you, on the log algorithm, it said to start out at like 100 of losartan. I usually start out slower after a patient's on a diuretic. What is the recommendation for starting the second agent in terms of dosing?
I typically start at 50 myself, but I think 100 is reasonable. I'd ask Dr. Wright, do you have any input on that?
Yeah, typically what I will do will be to hold your diuretic the first day, the day that you start the either the ACE inhibitor or the ARB. And yeah, typically 50 milligrams is the starting dose. A lot of it's going to depend upon the level of blood pressure that you're starting. Also, obviously, the higher blood pressure, you can in fact start at a higher dose, but typically you'll start at 50 of losartan.
Okay, thank you, Christy. Any other questions? See any on here? Okay, thank you, Michael. I think we can move on to. Oh, here's a comment. Some providers do not prescribe ACE for African Americans at all. I've had some ED physicians tell patients that it is an absolute contraindication. What do you think, Jackson?
Yeah, that's incorrect. Generally, for blood pressure control, ACE inhibitor by itself as monotherapy is much less effective in both lowering blood pressure and less effective in preventing the complications of hypertension. So that's why you use the ACE inhibitor, the ARBs or angiotensin receptor blockers, and the renin inhibitors, along with either a thiazide-type diuretic or a calcium channel blocker. So monotherapy with an ACE inhibitor or an ARB is not the best therapy for blood pressure control. But in combination with a diuretic or calcium channel blocker, it's very effective in lowering blood pressure and presumably also in terms of reducing the complications of hypertension. And certainly in the patient who has proteinuria CKD or with heart failure, then it becomes a primary, certainly an indication for the initiation of either ACE or ARB as initial therapy.
So along those lines, I just had one last question, I think, for both Jackson and Michael. I mean, I think that Jackson hinted at this, is sometimes the level of blood pressure has a great deal of influence on the dose that you start with. So most of my patients are African American, a lot of men with uncontrolled hypertension who haven't seen a physician for a while. And the blood pressure is well beyond whatever, if there was a stage 3, they'd be in the stage 3 range. And I'm concerned that they won't come back or they don't see it as a priority. So I actually will start them on chlorothalidone 50 and even start a calcium channel blocker at the same time. So Jackson, do you have any thoughts about a very aggressive?
For patients whose blood pressure is very elevated, then that's indication to start 2 drugs. The question becomes 50 of chlorothalidone. I think that would be the equivalent of about 100 of hydrochlorothiazide. And so probably not necessary. Probably you could still go with the 25. The other challenge is that you're at risk for hypokalemia. So that if they take the medication, those patients, many of those patients are less adherent to care. But if they are adherent to care, then you run the risk of hypokalemia. So that when I do start a 25 of hydrochlorothiazide, blood pressure markedly elevated, I'll add spironolactone.
Okay, I've never done that.
Yeah, and that is very effective in lowering blood pressure in patients with resistant hypertension, and also counteracts the potential for hypokalemia.
Okay. Okay, I know we've provided you with a reminder of this conference. This is the annual statewide conference of cardio. It's going to be on Friday, May 17th, back in Columbus. Our keynote is La Princess Brewer, who is from the Mayo Clinic, a sensational speaker. I've not heard her, but I've heard great, fantastic things about her. If you are interested in submitting a poster and presentation, I think you have until tomorrow to do so. And registration is now open as well. So keep that in mind. We had a great conference last year, and I'm really looking forward to this year's conference as well. Next slide, Rick. Again, you will get a post-clinic survey this morning. Please complete it as soon as possible, which is critically important, while the content and while the session is fresh in your mind. We do provide CME credit as well through Metro Health. And final reminder is that there is no echo clinic next week. I have a dual role as a hospital person, so they have, and you can't really get out of those, I've realized. You can move your patients around in your lectures, but you can't move the hospital stuff. So we will not have a session next week, but we will have one on the 21st. And Chris Taylor from Ohio State and Emily Guzman from OU will be presenting on lifestyle changes for blood pressure control. I'm really looking forward to it because there's a lot of great information there and that we don't take advantage of to a significant degree. So thanks, everyone. If there are no final comments, I think we will end just right on time. Thanks very much. Bye, everyone.
Bye.